Hey guys, Kim here, and you are tuned into Kim E, the Diabetes MP. Now we are in the month of February, and you know what February is? It's Black History Month. And so for the month of February, I'm going to do something that I've done for the past couple of years is I really like to talk about diabetes in the Black community. So if you have not caught the first video, I want you to stop this video and I want you to go back and watch that one and then come back and watch this one. That video, I gave a little bit of just a overview of diabetes in the Black community, gave some stats, also talked a lot about medical mistrust and language that we should use. But in this video, we're going to talk about the complications. And now, I do want to say this. There are many different complications of diabetes, okay? But I wanted to pull out the complications that are a little bit more highlighted in the Black community. And as a person who has practiced for almost 15 years as a nurse, and what I have seen in me being in the community health space, what I tend to see, okay? Now, something I want to say too about this is this. Not only is it Black History Month, but February is also Heart Month, okay? And so that actually is a complication that can happen if someone has diabetes. It puts them at higher risk to have cardiovascular risk. And so what I would like to do is to share some information because I do believe the more that you know, the more that you can grow. So I wanted to, share some information. I have stuff pulled up, of course, for my notes. And I want to talk about, helping your patients understand their risk. If you are a patient viewing this right now, I do want to highlight, knowing what your risk is and how to go about talking to your provider about your risk when it comes to cardiovascular disease, as well as talk about a couple of other complications as well. Now, one thing I do want to give as a resource, a couple of weeks ago, back in January, I did a great patient education Q&A with an organization called CMEO, or CME Outfitters, where I did a live Q&A. I also answered some questions on their Instagram page, and they also on their website, I did a patient interview where I did a lot of patient education with a real patient, not an actor, but a patient who actually is diagnosed with diabetes. And so I'm going to link all of that in the description box because that was a wealth of knowledge. But when it comes to your cardiovascular risk as it relates to diabetes, having diabetes does put you at risk for developing a cardiovascular disease, such as high blood pressure, cholesterol issues, and even something more advanced, such as stroke or a heart attack. And so it's something that we as providers, we must talk to our patients about. And at a point in time, these two different entities, they worked as two separate entities. There wasn't a big link between the two. We now know that there is a link between the two. And so even if a person has pre-diabetes, they really must, if you have a patient that has pre-diabetes, that should really alert you to do a full heart workup with them. And actually, the most recent ADA standards of care for 2023, it talks extensively about that. Like if a patient has pre-diabetes, use that as a smoke signal to say, okay, we need to really be talking about how to decrease their cardiovascular risk. So for one thing, I talk a lot about risk, and what I'm about to share with you, y'all have heard me say this before. I mean, it's not rocket science, okay? It's not rocket science, but people, I find that there are a lot of patients who don't know that they're at high risk, and they don't know why. There are a lot of tools that are out there. The ADA has a tool, a screening tool, as well as the AHA, the American Heart Association. They have a lot of tools that you can utilize, quick questionnaire that patients can fill out and can tell us how their risk is, how high their risk is. So I have a list here that I do want to read off to you of like ways that you can identify your patients, or if you are a patient, how you can identify if you are at higher risk for heart disease. Okay, so if you have high blood pressure, if you have high cholesterol, of course, if you're overweight or you're obese, that does put more stress on your system. If you have physical inactivity, if you are considered sedentary, if you have activity less than 3 times a week. That's a lot of people in our country. Also, if you have a family history already of heart disease, of early heart disease, that puts you at a higher risk. If you are a woman and you have had preeclampsia, that puts you at higher risk. If your eating behaviors are unhealthy. So one thing I would like to say, and I'll probably talk about this a little later, is about just, the conversation and the debate over like diet culture and, the anti-diet culture. And I do have some thoughts on that. I understand both sides, but we can all agree that there are some foods that are just flat out unhealthy. Like a quarter pounder and cheese is not going to help you with any health goal. Okay, it just is not. Okay, eating pizza excessively is not going to help you either. We know these things, y'all. So this is common sense, right? And then lastly, if you are a woman that's 55 or older, or if you are a man that's 45 or older, that puts you at a higher risk. And if you note that this actually, the age is less for men than it is for women, keep in mind that the more of this list that you have checked off, that actually increases your risk. Okay, so just keep that in mind. If this is you, definitely have a conversation with your provider. If you are a provider, you definitely need to be very attentive and intentional with how you deal with your patient, working them up and making sure that their heart health is where it needs to be. So I mentioned in the previous video, I talked about amputations and end-stage renal disease, and I want to kind of just talk a little bit about that. So like I mentioned in the last video, non-Hispanic Blacks are 3.2 times more likely to be diagnosed with end-stage renal disease as compared to non-Hispanic whites. And for those who don't know, I have spent a lot of time working in community health. Currently, my role now, I work with the CKD and the ESKD populations. And for the better part of last year, I worked extensively with the ESKD population, and these were people who were on dialysis. And you would be surprised, probably 90% of the people that I saw and sat down with, the reason what led to them being on dialysis and being classified as end-stage kidney disease was most likely because of diabetes. If it wasn't diabetes, it was hypertension. That was 90% of the people. That's 90% of the people. It could probably even be more. Now, there was a handful of people that maybe they had some type of autoimmune issue. Maybe they had something else that was going on. Maybe they had cancer. It's something like that. It may be some other issue. But the majority of people, it was because of diabetes and hypertension. Okay? And so when we are dealing, and you can find this in any guidelines for diabetes, one of the goals of diabetes management is to prevent and slow down the progression of complications. We want to increase the quality of life, and that's the big thing with complications, is that it decreases the quality of life that a patient has. I can tell you right now, and if you are a healthcare professional, you already know this, when people go to dialysis, and I knew this prior to working with people that have dialysis, but to actually see it is really disheartening, because people have to go to dialysis 3 times a week. And many of them go anywhere between 3 to 4 hours. That's kind of the standard. You go 3 times a week. You rather go Monday, Wednesday, Friday, or you go Tuesday, Thursday, Saturday, and you go for 3 to 4 hours. And it really kind of depends on the nephrologist. Most people go 4 hours. Think about that. That's 12 hours a week. If you're going 4 hours each time, that's 12 hours a week. And I find you'll see a lot of times people can't hold down jobs. People have issues with transportation. The weather can get bad. And this is a life-sustaining measure. So it's not like they can just go when they want to go. It is something that they have to do this forever. And actually the goal is to get people a transplant. And so people are put on this list, and it's just, to me, it's a process that it's very hard to watch as a healthcare professional, because many people who get to this stage, not all, okay, but many people who get to this stage, it's because there's been many years of uncontrolled, whether high blood pressure or diabetes. And so here recently, I have now moved over to the CKD side, the chronic kidney disease, where our focus is to assist with preventing people from progressing to the end-stage kidney disease. And so when I see this, and I see this stat, I know it's a true stat, okay? So as soon as we know that patients have diabetes, we need to immediately, especially with type 2, we need to immediately be getting other disciplines on board, so they have a relationship. They're having their kidneys checked. We need to be taking lab work. We need to be really pushing to get people to their individualized target as soon as we can, and really cutting out that clinical inertia, which is, for anyone who doesn't know what clinical inertia is the lack of progressing treatment. So a person is not being progressive in their care. We as the providers are not increasing the treatment to get them to the target. We're allowing them to stay kind of in a plateau, and so we have to dismantle that. So that's your end-stage kidney disease. But then when we're talking about our lower limb amputations, a lot of times how this starts for a lot of people is neuropathy, right? Most people with diabetes they're going to develop some form of neuropathy, but as it progresses, it can lead to injuries. It can lead to injuries that lead to amputations. And that's also something that is very sad too, to watch and to witness and to see the progression of that as well. This is where we as the providers really need to get into educating our patients over proper foot care. I have a whole playlist over diabetes foot care. Okay. So please, I'll link that down in the description box as well. But we need to be doing clinical foot exams. We need to get our patients to podiatrists, but we also need to educate our patients on how to properly assess and to do foot checks themselves, daily foot checks. Foot care for a person with diabetes is different for that person that doesn't have diabetes. We have to be careful, because we know that there will be some development of neuropathy. And we cannot reverse neuropathy. So what our goal is to try to slow its progression. Sometimes we're not able to do that. Okay. Part of that is getting people to their glycemic target. And so again, also not being lax with getting people to that target and really dismantling that therapeutic inertia. Okay, guys, I hope this was informational, and I hope that this has kind of opened your mind up to the different complications. I am going to link down in the description box, because I don't want to rehash things that I have already spoken about and have good videos over. I have done playlists over complications, and so I will link that down if you want to get more in detail where I've talked about it in the past. I'll link that in the description box as well. But if you're not, do me a favor, go ahead and subscribe to my channel, as well as ding the notification bell so you don't miss an upload. When I upload, you'll be notified. And then also, if you have not already, go back and watch the video that I just put up before this. You have been sitting here with Kim E, the Diabetes MP. I'll catch you on the next video. Bye.